Welcome back to the Health Impact audience. We're now in the final stretch of the last couple of sessions for the rest of the day today on Friday. And we've got a good lineup here of doctors, especially, and then also Vinod from the technology community, who we're going to bring into this conversation shortly to tell us about things that they've been literally begging us, advising us, telling us to do for years. Like I know Kimberly's been in telehealth for such a long time. Ashish has been pushing this literally like this mountain and a boulder up a mountain. Samir's been telling people in every state that he can go to is get onto telemedicine, get onto remote patient monitoring. And now all of a sudden, everybody's listened to you, right? So what you've been saying for years has now happened all in a very, very short time span. As physicians, what we'd love to do is to get your ideas on what do you think has worked well in that short transition, people, learning about telehealth and jumping into it really fast. You guys have had such long experience in the past of trying to push this that you probably adapted to it very quickly, but I'm sure you've had other physicians and clinicians around you that maybe did not. So I'd like to start off with that. What is working well in this very fast and rapid transition? Did telehealth end up being the way, and let's call it virtual care, maybe not telehealth, because that's a very specific technology, but let virtual care in general, meeting patients where they are, which is in their homes. What I'd love to hear from you first is, did it come out like you thought it would? Like if, in your dreams, you're like, everybody's going to go to telehealth and remote care and virtual care one day, and this is how it's going to be like. Is that how it is, or is it better, or is it worse? So Kim, let's start with you around, does it feel good where we are with virtual care, or very different than what you were anticipating when you were asking people to do it?
Yes, it feels great. I think it's telehealth's time to shine. And so it's wonderful to know that the value, no one can argue that there's a value proposition for telehealth anymore. So at least that part of the argument is kind of more subdued, I guess. But it's been an incredible journey, right? Where we see 4,000% growth overnight. I know many of my colleagues and I are probably can bond over the fact that there's about this 10-day period, at least in New York, being the epicenter of the COVID pandemic, that it was sleepless nights trying to get these programs up and scaled. So I think it's been really wonderful. I think we have a lot of work to do still. Accessibility remains a huge challenge. I'm sure we'll talk more about that. But we're hitting its stride. I think that we can only go up from here. There's a lot of fights to continue to make sure that we're lobbying for permanence, and happy to discuss that too. But
yeah, that's great. Tell us a little about Kimberly on your since you were prepared, very well prepared before the pandemic occurred, specifically around tooling and technology and processes. You had been working on that for years. Did much have to change, or did you scale all the choices that you had already made? You were just scaled, because some places they tried scaling what choices they had made earlier. It did not work well, so they had to go do a lot of mishmash kinds of new technology work very, very quickly. So tell us, did what you had before stay and just grow, or did you have to replace some of it?
So it was definitely scale by fire. I mean, I would lie to say that it would be so seamless of an ascent, but we had a lot of collaborative teams that had to work together under duress to make sure that we can meet all of the needs. I do want to stress, however, the importance of having the infrastructure in place. We had very advanced compliance experts who were familiar with the legal and compliance landscapes, so that when CMS would bring out new regulations, we could adopt, so we can move quickly. We had billing ability for telehealth, even though we were not rural, healthcare provider shortage area. So when the billing, became permissible for our area, we were able to jump in, and we've had high success and revenue because of that. We had educated physicians. We had a credentialing and privileging process prior to the pandemic. Obviously, with the need of turning the health system on a dime, that meant creating specified education regarding the new rules around the pandemic, and then creating a process online that doctors could self-attest. And literally overnight, we had 666 physicians become privileged in telehealth specifically. So I think we were primed. I don't think that anyone was truly, just ready to just float on to the ascent of telehealth activity. But being prepared, having effective teams definitely helped us scale quickly.
Great. So Samir, you've obviously been advising for many years for remote and virtual care, but in a thoughtful, disciplined manner. So it's not like you've been always saying everybody should just jump. So in this, was that, since there wasn't enough time to do the thoughtful, disciplined approach, have things come out as well as you think that they should have? Or did we miss some steps here where you're out in Minneapolis?
Yeah, it's interesting. I did my first telehealth visit 18 years ago in University of Utah for the Utah State Prison. I used to assist Bruce Bray. He's a cardiologist, and that's how I experienced my first telehealth visit. To spend the next 17 years hear people talk about it as innovation is sort of like a needle is being poked at me all the time. I think very similar to Kimberly, that we were primed to do many things around virtual health that came in very handy, no doubt. But from a scaling up, this was about getting the job done. Elegance and stability were not anybody's purview in the first 2, 3, 4 weeks. Also, I would say it's not that anybody listened to us, Shahid. There is that anecdote floating around: who's driving your digital health strategy, CEO, chief digital officer, or COVID? COVID. COVID
It's
drove
COVID,
everybody.
huh?
Nobody is listening to anybody per se. What has worked well is a lot of people and a lot of physicians and a lot of patients who had any doubt whatsoever about the viability of this as a clinical care methodology has completely been swept away, and that's no longer a question. What got cruelly exposed is that we did not have time to think of the patient experience and the quality of care being delivered. If you compare that to a clinic visit, an MA or another kind of assistant comes in, hands you over to the provider, who hands you over to an MA to finish the visit. A doctor just shows up and then disappears, and you're just waiting around. So what does the office visit in a virtual ecosystem look like is something that all of us are trying to architect, because patient satisfaction and experience are going to be the key drivers, and then also the experience of a caregiver in using this as part of their day. So really interesting work being done.
Yeah, so two things from a patient perspective. There's the accessibility, what Kimberly was talking about, and it's something as important as, do they even have devices and can they get to it? But even if they have the devices, the internet connectivity, the choppiness of the videos, and audio cutting in and out, not knowing when to start or what device to use. Do I use my iPad or do I use my Android? Or so lots of small problems seem like they were starting out at the beginning. Are we still seeing that level of lack of consistency, or has it gotten better?
Yeah,
for
lack
you
of
guys?
consistency is definitely there, but how I would, rephrase what you expressed slightly is that the challenge of access and equity in health outcomes were there before we started on this wave. And the digital way of doing things has exposed another area in how, when people don't have internet connections or have the ability to use a device because of a disability or age, and then may have the device but have just a text phone and not a smartphone, has highlighted that as we try to move in the direction of virtual care, we cannot forget that the issues around access and lack of equity in outcomes through healthcare have not disappeared. In fact, now there is another way they can express themselves. So we have to keep an eye on that and be very careful around how we think about it, because Kimberly spoke about reimbursement, and all of us are saying initially, at least, well, forget the telephone, but at least keep the video visits at par with a face-to-face visit. That, I think, would be a mistake, because telephone is the way only that you can sometimes get in front of disabled senior citizens or people with lack of access to good internet and devices. So to think of the telephone as less than a video visit in delivering telehealth would be, I would say, a policy mistake here.
Yeah, I totally agree. And when you think about it, Ashish, so you are like super optimistic about most things in medicine. And you've been, of course, pushing telehealth and remote medicine for a number of years, just like Kimberly and Samir as well. So tell me, I'm going to put you in an uncomfortable situation, which is, tell us what you're not liking about what's happening over the last few months around telemedicine. It could be equity, it could be access, it could be this inconsistency. What's not working? And it could be anecdotal. I'm not asking for necessarily, I know you run Node and you care about the evidence in medicine here, but just some ideas from you about, I really wished XYZ would happen instead of ABC would be great to get from your opinion point of view.
Right. So I think this has been just a fascinating era. I would say the only silver clouding or the main silver clouding I see from the COVID is digital health adoption, right? And we never had to force it. It's being pulled, right? Instead of pushing, it's like pull, and this is amazing experience. I have a little skepticism what's happening here. I think if I have to draw some negative things, I think first is we've already started seeing states turning down their licensing things. I'm in New Jersey and I go to New York. I practice in New York. This opened up, I could practice in New Jersey, the entire country for the first time. And New Jersey is locking that down, right? Mm-hmm. So I think I fear the old habits are coming back. And it hasn't fundamentally transformed the thinking. They still feel, oh yeah, we did WhatsApp, we did this, that's fine, we got around it. Now people are gonna come back face to face. It hasn't really changed the fundamental concept. This is a better care in some cases. Mm-hmm. This is actually preferred care in some cases for nursing home, for disabled people, right? The other part is we haven't had time to digest the learnings. And the learnings have been just amazing, right? So Samir actually pointed a very good point. When we were initially doing the measurement of telehealth, we went to around 6,000 telehealth visits a day, right? 30% no-show rate.
Really?
Right? 30% no-show rate. After 30% no-show rate, 70% people who show up, 20 to 30% did not have any kind of a video interaction, right? Or it was so fuzzy. So we actually had to also talk about the process and expectation to say, it's okay. In fact, you move to a phone. And even if you see actually for some time a video visit, you can still bill for it. And for me, at least in GI, you know how gastroenterologists don't even use the stethoscope that often. I just need to see a patient once and say they are healthy or okay. The rest of the conversation I can have on phone. Mm-hmm. And probably that was the golden nugget that probably need to be disseminated to everyone. Mm-hmm. Yeah, you don't need a full video visit, really. Your telephone can do such other stuff. So I think we need to still digest that, collate it, disseminate it and widely distribute it, and make those lessons learned as sustainable and continue the journey with a wider community. The biggest growth is it's not informatics. Mm-hmm. It's not digital health practitioners which are doing it. This is healthcare at large. And this is amazing dream for us. And that got fulfilled without us asking for it.
Yeah, no, that sounds terrific. And so, Kimberly, before I bring in Vinod, Kimberly and Samir, what kind of no-shows rates and stuff did you guys see that were kind of surprising with the telehealth side?
Yeah, I don't have access to that data. I apologize, but I just wanted to point out that Ashish is on record saying that gastroenterologists don't use their stethoscope much. As an internist, I find tremendous professional satisfaction from a poking perspective to acknowledge that. But no, I don't doubt that our data was any different. And it's a big frustration when you are trying to orchestrate telehealth, convince a physician to block out a little bit of their day when that's how they generate their income, and the patient doesn't show up at a rate of 30% or anywhere close to that. They lose interest. One of the failed experiments that I'm aware of in the past was related to fact that the notion was that a physician would carry a pager and every time a patient needed a telehealth visit, they would stop what they were doing and somehow find a computer and do it. Mm-hmm. So, it's easy to talk about it right now and say, oh, that was silly. But when you're doing it, you don't think of these things often enough. And all of us can do have examples of where we were not as thoughtful around the workflow design that now seems pretty trivial. So yeah, absolutely, I resonate with what he said.
Yeah, and so I almost, Kimberly, think of it this way, is it's almost like Payback, where we're saying now we're going to where the patient is, and the doctor is at the patient's waiting room. not the patient
Well,
being in the doctor's
it's
waiting
really
room.
like TOEFL, patient will see you now, right?
Yes, that's right. So
I
you
would
seen
say
similar numbers, Kimberly?
we had very different experiences. In some cases, we outcompeted our in-person um, productivity. Psychiatry, telepsychiatry had lower no-show rates than they have in person. And we have optimized a lot of services by enhancing digital navigation. As an academic hospital center, there are many clinical trainees, medical students, digital natives who wanted to help, but they weren't really able to be at the bedside, but they could help facilitate virtual appointments. So we had them troubleshoot with the patient, get them, walk them through downloading the app. We didn't have dedicated end user trainings for that, but it was really a great learning experience for them to initiate an appointment the way that's proxying what you're doing in clinic, right? Where they can introduce themselves and start with the history of present illness, etc. So I think we got creative really quickly. We did see, I kind of want to push back a little bit on the phone. Yes, the phone is the security blanket, but some say that the very first phone call by Alexander Graham Bell was a telehealth call because he spilled battery acid on himself and had to get Watson. And so if we go backwards in thinking that the phone is the end all be all, 100% behind policy support. I advocate that security blanket. We need patients to have access to care, period. But we also need to drive that innovation and bringing the technologies. And so at Stony Brook, we're really focusing on trying to bring, remote auscultation of heart sounds, lung sounds, get the new equipment in before we forget that, yes, medicine is complicated. And I think there's a part of this that we are afraid that a lot of patients with conditions delayed their care, are presenting now with exacerbations because they were just so afraid to get any type of care. Sure. And so there's a permissive, okay, we can order some labs, we can hold you through this difficult period through the phone, but I'm really trying to focus on the next level of kind of what Ashish was bringing forward about what about the skilled nursing homes? How do we scale really high quality care in the home that becomes really one-to-one? And so I would just say if we provide high quality service, I think patients will be lining up for it. Psychiatry is just so amenable to counseling that patients just, we were able to serve them seamlessly. And I just think for the other fields, the more we can incorporate higher quality technologies, I think you're going to see that same demand.
Yeah. Fair enough. I think that's exactly right. So Vinod, because you're dealing with a number of different customers that are going through all of this literally simultaneously, what are a few things that you see, the ones that are the most successful? Do you see them having a few different characteristics that makes them successful, or the ones that are not doing well? Do they have a few characteristics that make them not do well? Any commonalities?
Yeah, sure. Let me speak about providers, in our opinion and observation doing better than others. And I think what they are doing, and early on, it's not like they were waiting for COVID to happen. We have been working on, like Ashish and others, we have been working with these provider customers for almost 5-6 years, before. And we have been tracking some of the KPIs around no-shows and how, mobile applications and, portals and all these different technologies are helping to drop some of these KPIs and improve some of the KPIs. So I think one common, element that I see for providers who have successfully implemented virtual care is their passion for patient experience, right? Believe it or not. So they want to make sure that, patient can reach out to them at from their comfort of house, anytime they want, and so on and so forth. So I think patient centricity is one of the key aspects wherever I've seen, successful implementations. And not so successful implementation is obvious. Reasons are like, pushback from providers, to get on, as simple as opening their schedule, right, for appointments to be booked, right from there to technology barrier. And then other aspect I want to mention is really, as Samir was saying, COVID has, is kind of pivotal, right, for this whole acceleration towards digital care. And one of the shift I clearly kind of observed, and I would like to mention this, is shift from stating problems to finding solutions, right? So earlier providers were looking for reason not to do it. But now with COVID, with the revenue situation and, all host of reasons, we know it is shifting towards finding solution for the problem. I think Samir brought a very, very good point that, earlier, whenever we used to have this discussion, it was like, oh, my, patient population, 30% do not use smartphone at all. But now, same providers are kind of, adopting digital care wholeheartedly because they know, they cannot care for patient, unless they adopt this new channel, right? Which is like fundamental shift I see here now. Like everybody's on solution side rather than problem side, which is like very interesting to, observe.
No, that's a great point. And so let's talk a little bit about taking those quick lessons and moving to one very, very important topic, and that is not so much reimbursement, because the idea of reimbursement, people understand that if we do reimbursement, it will be used and there is benefit. I want to move to the kind of like the realities of people who are submitting claims. Are they actually getting the money? Are they getting the full money that that they thought that they would be getting? And Kimberly, you talked a little bit about the billing side, that you were prepared for that. Are you surprised by anything? Is it being paid at about the same rate that you were expecting? Much lower, higher? What does that reimbursement look like for you guys?
Yeah, we just had a meeting with our chief of billing, and it's amazing. We're getting paid the same, the exact same. And so
the money is actually
that's
making
not
it into your
incentive
account,
enough.
right?
Yeah.
Okay, good.
The claim denials are at the same percentage, very low percentages that they are in in-person care. So when you have increased activity in certain fields, it sets the bar for digital transformation. Mm-hmm. We are at risk now. Ashish is talking about the tides turning back. I'm concerned about insurers mandate. What about when they're charging copays? Right? That is a huge logistical challenge to collect the copay. And when we think about reimbursement parity, how are we going to scale the technologies and invest in innovations with a promise of diminishing return? In a setting where healthcare systems are in financial deficit. So it takes very forward-thinking, non-risk averse leadership to commit to the future of digital transformation. Mm-hmm. And it's interesting.
Got it. So Samir, what are you guys seeing as far as payments and other things? Obviously, you're probably getting a financial impact, so that's understood. But from the telehealth portion, are you optimistic about getting better and improved payments, or pessimistic about it going forward?
I guess I'm a realist about it. We're getting the money is coming in right now. We'll see how long that lasts. A lot of states are, turning it back in very interesting ways. They may still give you the same amount of money, but now the licensure requirements have become strict. Wisconsin, rolled back the ability for us to serve the patients who are just on the other side of the border, but we are the largest city that they are near to. So that's, become an interesting challenge. We are pushing forward in the sense that all the service lines that have come together in the last 3-ish years, and more so the last 1 year, are making plans to keep at least 50% of their clinical care virtual in some shape or manner. And that's a broad definition. Kaiser will speak about how more than 50% of the care is virtual. They count email as part of that denominator and numerator, and I think that's just fine.
Yeah, I
so
agree.
We are also going to have a liberal definition there, and want to make sure that any patient engagement, clinical care, we try to achieve for the 50%. And the reason for that is multifold. One, it's meeting the patient where they are. This is going to be the consumerism era of healthcare. So who's going to succeed are the people who understand what is it that a consumer expects. Secondly, by having more virtual care, we are able to offer our services to a larger group of people in the market. So there is a lot of focus on how to understand the market dynamics and really start thinking like a retailer or a banking industry to really put the consumer in front of us. And then the third aspect is the more virtual care you provide, you have higher access, not just through virtual care, but through your brick and mortar. All of us have, meetings where we look at how can we move our 3-day access to 2-day access. Oh my gosh, this is 14 days. How can I bring it down to 18 days? Well, if you move a significant portion to virtual, then you get closer to the ideal state of 1 or 2 days and you have an appointment for anything you want. And especially in primary care, you get same day appointment. So the any effort in this space really rethinks access differently, and especially in primary care. So yeah, we are going to push forward. The balancing here is the financial viability of all these projects. So really having good business plans that are thought through. You want to make sure that when you create space in your clinic, by seeing less level 1 patients, you're able to see more level 3 patients. You can't have your doctor in the clinic sitting, without any, patient flow through them. So that's, making sure you have a good business plan. But we are going hard at figuring out how do you create service line workflows where at least 50% of the care is driven virtually, but we still maximize on the in-clinic, in-presence meetings, fully recognizing that the revenue will be impacted on the virtual care side in some shape or manner. But also that if we are able to get the patients who need our care the most and are the most complex, things will even out or maybe even get better.
No, that's very cool. And so Ashish, Vinod said something profound, which is that the ones who are succeeding care about the patient experience, and maybe there's something about them that is making that success happen. But even if we meet the patients where they are and we care about their experience, you still have to afford it. What are you thinking about how we're going to be able to afford this now that you've seen that it is possible to do? One thing we did not know a year ago when we were having this conference is it was just a pipe dream, like somebody might do it, might not, but now, we know now it is possible. We're not quite sure if it's affordable. What are your thoughts on affordability here?
I see affordability lens from 2 points. Technology itself, digital health. I truly believe, like, WHO used to call healthcare for all. That is very tough to achieve because logistics of time, space, and person are something that are never infinitesimally available. Right? So you cannot make it affordable for all, nearly everything. But digital health, you can make potentially affordable for all, right? What is the cost today of a telemedicine call, technology cost? It's zero. It's actually zero. WebRTC framework with just telemedicine is actually free open source network. As far as there's access to broadband from a patient side, access to broadband from your side, the actual technology cost is zero. All the cost we are seeing from technology side is implementation or licensing and those kind of things. But its actual cost of telemedicine is zero. Let's talk about other things. We're talking about telemedicine, but I feel the biggest learning, biggest upside we're going to see from COVID is actually the next wave of digital monitoring. Yeah. Right? And that's because telemedicine is not fundamentally changing care delivery. It's swapping what we do one-to-one in person and making that one-to-one virtually. But we still have to do the same time commitment from an expensive physician to a patient, right? Where really the things become affordable is one-to-many. The same thing if I want to tell my patient about how to prep for a bowel prep. I'm a gastroenterologist, talk about stool all the time. Can I make it to give to 1 million patients without spending a single moment of my time? And it can automatically keep on reminding patients before procedure, like a virtual AI, right? Cost for that is pennies per patient per interaction, right? Versus a phone call, which is around $1 to $5 per patient based on what it is, right? So I think if we are somehow able to create a buffer within our health system, right? Which says, so the major challenge for affordability is not technology cost. It's are we getting reimbursed for the technology, for the operational cost that comes to us? Or we just take a very bad, poor choices for technology, we make it in that regard. So as far as it's getting reimbursed to some degree, or we have a buffer in some degree, we can keep on experimenting and actually achieve Samir's 50% virtual care level. Mm-hmm. And even going beyond telemedicine as a virtual care level. I love the fact we need to start anchoring our health systems in terms of numbers and percentages of value-driven initiatives. Because I'm doing telemedicine 1 out of 100 visits or 50 out of 100 visits is a very big difference. Mm-hmm. But if you just go and say, I'm doing telemedicine, anyone can put the flag up and say, I'm doing telemedicine, right?
Right.
So that's where efficacy, effectiveness, value creation lies when we start talking about numbers and keep moving the radar up. So I love that number.
No, that's very wise. And I think that when you look at it, Vinod, from the health systems, so you've got three leaders from health systems sitting here, how are your other customers thinking about this? Can they afford it? How are they going to get paid for it? Where do they sit in the middle of all this? Or are they just thinking right now that, hey, we can't worry about money right now because in the middle of COVID, just do everything and we'll worry about affordability later? Where do some of your customers sit?
So I kind of, it is a mixed bag. I think what Ashish said is, great point. And I kind of, if I look at, customers that we serve, most of them are kind of aligned to that thought process, right? We work with a lot of innovative AMCs and, leaders in the space. And, there is like a whole spectrum where these leaders are thinking way ahead, right? So we are working with one of the AMCs where, where telehealth is just kind of a channel where it becomes means to deliver care where patient is, and then, Samir was mentioning about level 1 and level 2 and level 3 patients. And that's exactly with, we are working with this particular AMC on what we call care pathways, where we are providing care to hypertension patients. And there we are managing almost 5,000 plus patients using telehealth as a basic channel. But it is kind of extending that further and saying, hey, can I use algorithm and machine learning to monitor this patient, and when certain biomarkers are out of threshold, then basically this algorithm will proactively alert navigators and other care team members, and then whether algorithm itself will talk to patient and ask them to do certain things, or the set of care team who is sitting there for that patient population will basically guide this patient for next set of action and tasks that they need to do. So it has reached to that point, already where we are using telehealth as a channel, and we are really delivering virtual care, from that perspective. Coming back to your affordability question, this whole equation is going to change in my mind, right? Because what is happening is that as Ashish said, technology is affordable, and more innovation is happening. It will be more and more affordable. I think important point that will drive behavior from my perspective about health systems is going to be reimbursement. And those rules are changing, and I really hope, I think all of us hope that they'll remain there beyond COVID. So that is one part of it. The second part is, other health systems who are getting into this journey. COVID kind of forced them on this journey. And I think they're now looking at, how do we make it happen, and then they're finding ways to kind of make it happen. And from, as Ashish said, that implementation cost is the only cost they have. And then reimbursement, at least for now, is there. We'll see what happens in future, right? The third aspect I want to introduce to, this concept is basically competition. Because, that a lot of retailers are kind of eyeing, and making sure that they will compete with this health system. And that makes whole equation very, very interesting. And health systems are, I think they are forced to look into this aspect very seriously now, because all these things are coming, right? And then technology is there, and all of us kind of were kind of bearing this flag and asking these health systems to get on this bandwagon. And I think this is great opportunity for health systems to not just, as Ashish said, like not just have a video conferencing channel and call it a day. I think we need to think, how do we go beyond and then really cater to, chronic, disease conditions or chronic care for the patient population, and not only chronic, but going beyond, right? I think, and it will happen. It is bound to happen if you look at the economics, of this the entire space.
Awesome. Well, terrific job, all of you. And whatever problems are left, Vinod is going to solve all of them. So we'll catch up with him afterwards, given that's what he's been doing for the last number of years with other providers. So with that, I thank all of you, Samir, Ashish, Vinod, Kimberly, for participating. We're going to open it up now for questions from the HealthIMPACT audience, which can be pretty smart on its own, and they're going to ask some pretty helpful questions. So with that, we'll let the team open that up now.